All right, welcome back to Basically EMS. My name is Kylee.
I'm Chris.
I'm Dawn.
We're going to be talking about community paramedicine today. And Dawn is not only the only and probably one of the first community paramedics I've ever met, but arguably one of the best people to be here to talk about it. So thank you. Thank you for joining us. Yeah. Yeah. So I know there's a lot of people out there that just don't have any idea about community paramedics. If you could keep it like fairly straightforward, how would you describe?
So community paramedicine is kind of one of the many terms that people will use. Mobile integrated healthcare is another one that's used as a blanket terminology that includes all levels of providers. So it's not just medics, includes NPs, PAs, nurses. In Idaho, it's called CHEMS for Community Health EMS because they wanted it to be inclusive of all levels of licensure. But really what it is just a different way of doing what we do already, which is, responding to people with some sort of complaint and deciding in a different way what to do. Instead of just let's take you to the ER, it's figuring out kind of what the root causes of somebody's complaints are, the long-term, consequences of what they are and are not managing well. So it kind of comes into different varieties. There is the response in the field, and then there's a lot of follow-up care that some programs will follow up with people that are discharged from the hospital that are high risk for readmission. So it really depends on. There's the saying, if you've seen one EMS system, you've seen one EMS system holds especially true for community paramedicine, which I personally do not like because I think that, that's part of the reason why EMS is not advanced very well is because we don't have a cohesive scope of practice, a cohesive set of all kinds of stuff. So community paramedicine has been that. It's been around so the first program that started when I started, everybody always credited it was Red River in New Mexico.
That was the first
real
program.
I don't know if they even called it community paramedicine. It's been a while since I kind of looked into it. But
that's where you went to school?
No. So this was a program. So this was a EMS system in New Mexico that, due to socioeconomic issues, had a lot of people struggling with chronic health issues, readmissions. So they recognized that they were in a position to be able to go into people's homes and help them manage their chronic diseases and kind of moving from there. Got started, the physicians, they, allowed for some expanded scope with some of their medics, and then it kind of petered out. When the department that I worked for started, it was in 2011. So we were one of the first in the country to kind of get started moving forward on it. And everybody was just trying to figure out, what is the best avenue of what's the best for your community? What does your community really need? We started looking into programs that had a lot of congestive heart failure and diabetes and COPD patients. High
involved in care, those types of patients.
Turns out most of the people in this area are fairly healthy when you look at national. You don't go to the Southeast.
Yeah, 'cause you were saying comparatively where we are is actually quite healthy in the big picture.
Yeah, so it really became we spent a lot of time figuring out what was going to fit best for the community here. So that was kind of a long round of answers.
That's a great one.
And you were part of the team that started the program here?
Yeah.
That's so
there
cool.
were 4 people that were hired to start. And we, like I said, really just started from scratch. Our director at the time, had a vision for moving the idea forward, but really was it's up to you guys to do the legwork to reach out to insurance companies and physicians' offices and hospitals and all the other stakeholders we can identify to figure out what pieces are missing and what can we, as EMS providers, where can we kind of fill gaps? And so that's become most paramedic CP programs. Their mantra is filling gaps in services. So.
Did it start with medics then and then kind of expand out to the NPs and PAs and all that you're talking about? That's cool. I can't think of a better person, really. If you think about people that know the holes or see the holes, you talk about your doctor's office nurses and things, and they see some of those holes, but we see it at home.
Yeah.
And that's cool.
It makes a huge difference. I think, there were a lot of the stories that we heard when we were doing some of our initial education and then reaching out to other programs around the country. So at the time, Pittsburgh had a big program. Minnesota was really moving forward. Nevada, REMSA got a grant to move forward.
That's right.
And so we all did a lot of collaboration. Colorado had some programs that were, blossoming. And at the time, because there were so few of us, we did a lot of collaboration. And, you'd hear the stories of one of the classic ones you hear is the person that was labeled a drug seeker because they kept going back to the ER and looking for prescription refills. Turns out they had an apartment and were living in a fairly unsavory part of town and didn't want to get any of their family members in trouble for stealing their meds. So they got the person a gun safe so they could lock their meds up.
Wow.
Another one was somebody that had repeated congestive heart failure exacerbations that lived on the third floor in a place without an elevator. So because they were able to see that and recognize like this is not, that team there, I believe this was in Texas, was able to work with the person in the rental, the company at the apartment and get them down to a ground level floor. It's just things like that like you said, the physicians and people in the buildings don't see how people have to live their lives. So.
I've always kind of when I've just introduced this to my students, described you guys as like the social workers of EMS and and that might be a bit of a misnomer, but just kind of off your description now, that's filling the holes or finding the holes and helping fill them. Like that kind of reminds me of how I leaned on the social workers like in the ER.
Yeah.
And I mean, what you were talking about, those stories, like I called you on many calls and was like, hey, I don't know what to do. Is this something the CPs can do? And personally, I made a number of referrals to the CP program just because we see it, and we feel horrible. I know we all have those patients where we were like, I can't do anything, so I remember that being an option and being like, oh, thank God, there are people who are not only better at it, but there's actual training.
And it's, and again, it's different in every community. So it's not everyone has the same kind of focus that we do here. There are places that are what they call more like physician extenders, where they it's almost like a kind of a step below a PA. So you really, especially in rural areas, are working with more of an expanded scope of what they're doing in the fact that there's just healthcare provider deficits. So they're utilizing the people that they have.
I'm a rural kid. So I think about, or I hear you talking about stuff like that. And I'm like, just that one role would have probably made waves in my community. Yeah. It was very small.
It is perfect for rural areas. It is, however, the logistics and the funding and the reimbursement for it are a nightmare. So,
I mean, I don't want to say that makes sense because it doesn't, but it makes sense. Yeah. That kind of thing is new and hard, probably kind of hard to prove.
Well, it is. And they, so it's been, 14 years since we started and I feel like that nationally it really took off and not very many people have been able to really crack the reimbursement egg. So it's
is the argument that CPs can't be making those kinds of calls?
Partly. I mean, it was just the way that reinsurance reimbursement set up is EMS it can only bill up the transport.
So it's still under EMS specific billing, not like a preventative or...
So but the codes exist in certain, but they're state specific. So Idaho did create specific community paramedic billing codes. Blue Cross of Idaho has community paramedic specific billing codes. The problem is, at least when you're and I don't pretend to know all of this law. So, but what I have been told is that you can't selectively bill for services. So if you offer a service and you provide it, you can't only bill the people that are on Medicaid, for example, or only bill the people that have Blue Cross.
Right.
You have to bill everyone. And so it becomes then people are like, well, no, I'm just going to go to the hospital then because I don't want you to send me a bill for something when I could just have my insurance covered if I went to the hospital.
Yeah. So then the community paramedic programs probably do best in municipal systems then, unless third party driven, your AMR.
I don't know that there are very many private EMS companies that have community paramedic programs.
So clearly funding out on top of everything else.
Yeah, it's a huge issue. And it's, there's the grant funding, there's there are places that have created partnerships with health systems that have been successful. Minnesota has really been progressive in that.
That's what I always heard about.
Yeah. And their state legislature actually created, like I said, some more kind of guardrails around community paramedicine. I think that's part of it too. Is that, talk about education of the providers. There isn't any standardized. There's no national standard for CP education.
That's where I was going to kind of go next was some of that education stuff. Because part of why I was asking, like, are they saying community medics shouldn't be doing that? Is like they always come at us for like our education, because there's a lot of certificate level providers out there, and they say like you can't or you shouldn't. You're not capable.
Yeah. So there aren't, like they said, there's no national standards. There have been a few states that have created standards for their community paramedic providers, or whatever they decide to call them. I worked on a project that the state of Maine was coming up with education standards for their all three levels of providers in the state.
Wow. All three.
Yeah,
that's awesome.
Yeah, it was a cool project to work on. Of thinking, especially Maine has got a lot of rural characteristics similar to Idaho on how you create a program that empowers basic level or intermediate level providers to really do the best they can for their community without requiring, a medic to be there. So it was super cool. But not every state's been that forward thinking on it. So no national standards, very few state standards. And so that therefore leads to some real issues with billing when you're trying to bill for a service done by a basically non-credentialed provider.
Yeah.
So
interesting.
Do you know, is any of this modeled after other countries and other health systems of what they're doing? Are there places that have, more socialized medicine or single payer kind of insurance schemes where this works because the funding is much more accessible?
They do it in the UK, don't they?
Australia and New Zealand are both, all three of them, big proponents of the community paramedicine.
The NIH and all that in the UK, I think, manages that.
Canada also has pretty robust, different levels of providers. There's actually a group called the International Roundtable of Community Paramedicine, and I've gone to a couple of their conferences and met people from all over the world.
That's so cool.
It's really cool, but it was frustrating as a new program, and you're hearing about these people that have worked in single payer health systems where their outcomes, their ability to communicate with providers, their being able to pull somebody's complete medical record,
overall preventative scores
is so much easier.
Yeah.
Yeah, that's part of the reason that a lot of EMS systems struggle with integrating into health systems is our charting systems are not set up for that, and our information sharing back and forth with health systems is not set up for that. So
there's like no governing body. There's
no. There are there is a National Association of Mobile Integrated Health Providers, which is similar to like the I guess NAEMT.
Yeah.
And then there is NAEMT has they have a similar to PHTLS. They also have a CP program, education program. There is the International Roundtable of Community Paramedics. And then the IBSC, the International Board of Specialty Certifications, that give you like your critical care paramedic, flight medic. They also have a community paramedic cert.
Well, and that's kind of what I was, when you were talking about like there's no standardization or whatever. The program that I think of is here local. And that's the one I kind of grew up around. So like,
which is no longer
is it?
Yeah.
Oh, that's
funded by a grant. So,
was it? Okay, because that was going to be my question of like the university this is associated with is not small, but it's not big. And so I can't imagine that like if it's not standardized and unless your local 911 service is directly probably feeding into that, it's probably kind of hard to maintain, huh?
Yeah. Yeah. And it was funded by a grant and, met with a lot of enthusiasm. And then
I wanted to do it.
Yeah.
I wanted to do it. I think I talked to you about it.
Yeah. It was grant funding ran out, and then the enthusiasm ran out because the focus was really supposed to be the rural areas, and it became very apparent how difficult that would be to maintain that. Rural areas struggle to maintain providers, period.
Yeah.
Much less adding another role of provider that's not reimbursed for what they are going to be doing. So,
and especially such a specialized provider that unless they're heavily experienced dueling as, that community experienced enough CP and then, whatever street medic or whatever, that's enough for a job, and they usually can't pay for that.
And it's, the experience that I had in the rural setting, we're trying to bring community paramedicine to a rural area, was met with a ton of licensing and all kinds of issues that I hadn't anticipated when I initially took the job of, how do you maintain proficiency as a medic with a system that runs, less than 500 calls a year?
Right.
How do you keep your license when your agency that you're affiliated with is a BLS agency?
Yeah.
How do you
I didn't even think about that. If you're not a paramedic system, you can't have
Yeah, we had to find some creative workarounds in order for me to keep my license when I took that job. How do you community paramedicine for, like the scheduled things. So they follow up after hospitalization, checking on somebody's medications and their ability to monitor and utilize home medical equipment is scheduled, and EMS calls are not scheduled. So the whole idea was like, you could do this in your downtime, but you can't schedule an appointment with somebody when you don't know when an EMS call is going to come in if that's what you're supposed to be available.
You don't know when your downtime is.
Yeah.
So hard to schedule that out.
Yeah. So it sounds like a great idea. It turns out it can be really, really difficult.
And then from a scope perspective, whatever your medical director?
Yeah, similar. Obviously there are limitations within the state scope of things that you can and can't do. But the, medication administration, and basically a lot of it is done under the, the guidance of your medical director. And, there are places that, like I said, the kind of expanded scope that, allow CPs to do sutures and,
like that paramedic practitioner's similar role?
Yeah. Those are like fewer and far between because it's a level of competency that's really difficult to maintain. So,
has that been something you noticed? Because are you running or doing like street medic regular 911 call stuff?
Just doing CP stuff now.
Have you picked up overtime or anything?
Yeah, it's kind of scary.
Well, that's kind of what I was wondering because that was going to be my next question is like paint the picture of what like a typical kind of call looks like as far as like do you do EKGs and like that stuff. But I imagine there's a lot of those skills that like there's a ton of stuff included in our license that you probably like your med admin and stuff like that are actually maybe covered by.
Yeah.
But then you think about it and you're like a behavioral subject.
Yeah.
Probably doesn't need a 12 lead.
No. And it's, again, it's different for every program and what their program looks like and what are the things that they concentrate on. Obviously, places that are doing really intensive congestive heart failure follow-up are doing LASIX administration in the field. There are programs within the state that are called hospital at home, utilizing medics and are, monitoring infusions for antibiotics and really kind of that, again, similar to like what a physician extender, where it's meeting somebody, keeping somebody at home while they still need like hospital level care. So that obviously is very different than what my program does, which is mainly, resource referrals and diversions for psychiatric patients. It doesn't mean that you lose your competency in medicine depending on your program. It's just different.
Sure. And then as far as like the whole, or I don't know if you're like allowed to talk about this, but like as far as your community, you were a 911 street medic before you went to that CP side. Have you seen like a difference in the community or like, between those two things? You went in with street experience and now you're focusing on like those holes and stuff. Has that changed your view from being a CP now compared to?
Yeah. I think one of the disservices we do in initial education for EMS providers is we don't focus enough on social determinants of health, mental health, de-escalation techniques, and just the challenges that people have because of those social determinants of health to maintain their health.
Can you describe what that is really quick?
So it is. I mean, their saying is that your health outcomes are more predicted by your zip code than your genetic code. So people that struggle with low or no insurance, low or no health literacy, poverty, food insecurity, housing insecurity, all of those things make it very hard to manage a chronic medical condition. And so they get labeled as not
Difficult.
compliant. They get, it's like, well, why aren't you taking your medications? Well, the doctor prescribed a medication that costs more than my food budget for the month, and I can't take it. So, and people, for the most part, and this is obviously a gross generalization, but aren't comfortable speaking up to their physician and saying, I can't afford to pay for this. So they just won't take it. And so then the
We've all seen that.
Yeah.
We've all seen the outcomes of the high blood pressure or whatever.
So that it definitely it opened my view of seeing, I think, more of a holistic view of people.
I like that, a holistic view.
It's been awesome, and it's increased my ability to be empathetic to people by leaps and bounds, because you realize it's not just a clear cut, like, well, why don't you just do this? There's a multitude of reasons why people don't do that, whatever that might be.
A lot of bias, I would imagine, that, and for our roles as like instructors, I think, especially here though, we've all made it pretty clear that like we want to deter away from that as much as possible. And like it's uncomfortable, but you have to talk about it.
Yeah.
Not it's going to come up anyways, but then there's roles for stuff like this.
I think the other thing that I've learned was how little we know about the healthcare system as a whole as medics.
Oh, sure.
We think we know home health. We think we know hospice. We think we know what happens in the hospital. We think we know what happens when somebody gets discharged from the hospital. And we get little tiny people, unless somebody's had a personal experience with any of those things with a family member or so. But understanding more in depth of the process of all of those things was very interesting. The idea, we get phone calls in our program for referrals from our field providers that will say, well, this person needs home health. Like, well, that's not just something that you get. It has to be ordered by a physician.
Check that box.
It's time limited.
You're like, you bet.
It is for a specific condition, and they get a certain amount of visits.
And they get billed, and they only get so many hours. And
and it's not home care of helping somebody with their ADLs of bathing or making food or cleaning their house is usually not reimbursed by any insurance. So people have to pay for that out of their pocket. A lot of people don't understand that going into assisted living is out of pocket. So we really, again, like I know there's so much crammed into EMS education with the expansion of all of our base of knowledge. But I think we really do a disservice by not emphasizing enough what people what our patients have to manage on a daily basis.
If you've ever been sick, like just not even just like I have the flu, like you had something come up and it took 2-3 months out of your life.
Yeah.
And you had to pick up the pieces for 6 months. That's one thing I always thought about. Like, I got sick last year and it took me months and months and months to recover. And I'm still capable for the most part, but I still struggled. Imagine being someone out here who has CHF that has no family, who, I don't know if you guys have heard this. This is a great time for it, but 911 is the best healthcare that minimum wage can afford. And it sounds harsh, but like I teach my students that. And I'm like, you guys don't realize like people are elderly, they're alone, they have complex diseases. God forbid they get sick. God forbid something happens with their income. It's a very slippery slope, not even with health.
Well, and I think there's people have asked when we, have these kind of roundtable discussions of providers and stakeholders and things, if you could fix one thing, what it would be. It's like transportation, like getting people to other places other than the ER when they don't have the ability to transport themselves, especially if you live in an area that doesn't have great public transportation, would make a
big part of our
difference.
Area. Certain
most places in the U.S. really.
That's a good. Actually, most places we're so big. And that kind of infrastructure takes decades.
And it's a difficult thing to convince people. If you have a doctor's appointment and you don't feel well, like let's take a bus that's going to take you 45 minutes to get there.
And you have to sit at the bus stop. And
Yeah.
Do you feel like this change in perspective of having worked as a community medic has changed your street medicine at all? Just running normal 911? Has that changed?
Yeah.
And in what ways do you feel like it's kind of affected a change on you?
After I became a medic, I think that there was like a fairly common grumbling about working with me because the calls took a lot longer. Obviously not emergent calls, but, because I wanted to spend the time to figure out, like, well, show me how you keep your meds and where are they? And do you have problems refilling them? And do you have a primary care physician? And, I had a partner once say, I've never been on this many mental health calls in my career. I'm like, most calls are mental health calls.
They have a root in mental health.
If you dig deep enough, most of them have that somewhere, the somebody that's complaining of chest pain or shortness of breath, and you start, looking at their face and realizing that they look very anxious. And you ask, like, what's going on in your life? And then, like, I'm not a hugger or really a very emotional person, but the number of times people have started crying in front of me.
How are you?
Yeah.
What's going on in your life?
Yeah.
How are things?
That's which, I had to learn really quickly to stop my initial reaction, which was like, please don't do that. Because I'm like, well, you asked. You have to
Grab it upon yourself, Don.
Yeah. But it, and I think there's been a change in the ER as well when we and my interactions, obviously, when you first start doing this, when medics first started in general paying more attention to somebody's home environment and their medication storage and their, like, the socioeconomic issues.
Your scene size up.
Yeah.
Actually doing a real scene size up.
Some of the ER, nurses and would look at you like, what, thanks. But now, I tell all of our medics, like, if you see something that is concerning to you about their living conditions or their ability to obtain whatever, find the social worker. Most of the ERs have social workers in them now. Talk to them. They give the nurse a report of what you did, medical, whatever, but find somebody that's their job because these things get lost in the shuffle so easily. And then this poor person ends up just being another, like, it's frustrating to people when they say that, I went to the ER and they didn't do anything. Well, you have to remind them, like, the ER is there to keep you from dying and then shuttle you off into somewhere else. But for folks that don't know how to access care otherwise, are, unable to do so in whatever way, they feel like they're just constantly getting passed around and in a way that is like, well, I guess I'll just keep going until somebody does something for me.
Yeah. Well, and two, one thing that I always thought was interesting from, like, just talking to you as well when we were working together was, like, the medication side of things over just how complicated that can get. And it reminds me of, it wasn't a call I ran, but it was when someone else went on, and it was for a little kid, and the kid would not take his seizure meds. And the parents were like, is this, what is it, oppositional defiance or whatever? And it turns out the kid had OCD and he only wanted to take pink things or something like that. Yeah. And it took a provider being like, why don't you like taking this? You need to take it. And the kid just had a legitimate OCD. Yeah. But they went to a compound pharmacist and the problem solved. Kid quit having seizures because he was able to take his meds. And while that's not the same as, like, the community paramedic, I think it's kind of a parable to, like,
it is. We have such a unique ability to see into someone's life and see, what really gets missed in the ER, what gets missed in doctors' offices. I remember standing up in front of a group of physicians once and telling them that, we had a patient, this was years ago, when there were a lot more uncontrolled diabetics or poorly controlled diabetics. Now with, pumps and CGMs, like, there's not very many. We don't have it very often. But I told him there was a gentleman in our community that EMS responded on 42 times for low blood sugar and transported twice. And they were shocked. I said, and if we didn't communicate that with you, there is no way that you would know that. You just wonder why his A1C was, 11 or whatever. So we really do have a unique insight. The number of people that have non-injury falls, multiple non-injury falls before they fall and get injured, and their physicians had no idea because people are afraid. An elderly person is afraid someone's going to force them out of their home if they admit that they're having trouble, managing it. So, we try to tell people when I visit them after a fall is, our whole goal is to keep you home and safe. And it is not to, drum up support to put you into a facility.
Right.
Most people don't have $6,000 to $7,000 a month to go into a facility.
Yeah.
So, but they're afraid, and it causes a lot of, hiding of bruises and numbers of falls, and the fact that, they're having difficulty. So when you can really open up honest dialogue with somebody, see their home, see the difficulties they're having, it makes a huge difference in finding the root of it and trying to keep it from, getting worse.
So then you're talking about like the community medic side, and I know there are other people that work with you or like maybe alongside you, right? What can you tell me about that?
So
like that team?
In our program, because we have such a huge focus on mental health, we work really closely with law enforcement and the law enforcement CIT teams. So they're social workers. When we first started our program, we worked, side by side with social workers from the state. The state removed that mobile crisis unit from the Department of Health and Welfare and moved it to private. And there are now mobile response teams that work for the contractor for the Medicaid contract.
Oh, that was going to be my question. They're contracted then?
That respond, and they're dispatched out of 988. We don't work as closely with them because obviously we're not dispatched out of the same sorts of systems, but we do kind of work in parallel. We call them frequently after we've seen somebody that doesn't meet criteria to either be inpatient in a psychiatric facility, doesn't need to go to the hospital, doesn't want to go to the crisis center, and a lot of times we can call 988 and ask them to have their providers follow up with the person and send someone out to do an assessment. So,
and 988 is a number anybody can call for behavioral symptoms, behavioral. They're just
and the mobile response teams respond to anybody regardless of insurance or.
And is that a national service or is that just through the state of Idaho?
It's the state of Idaho. There are other states have similar things, but this is.
But 988 is for Idaho.
No, 988 is national.
Oh, 988 is national. I see.
But the response teams are individual to just certain states. But
I see.
Yeah, 988 is a very important number that everybody should know.
Yeah, that's why I want to clarify.
Yeah. No, it is. It's the national hotline basically to reach your local suicide and crisis line. They had some issues for a while there. If you had an area code, like if you newly moved to a state and you had an area code from a previous, phone, then it would go to that place, that center. I think they've mostly corrected that now because there was a big concern about nobody wants to use, tracking on someone's phone to figure out where they are because of privacy issues. And that's part of the thing with 988 is it's, anonymous. There are people that are afraid that if they call 988 and they confess that they're, confess or discuss the fact that they're feeling suicidal, that they're automatically going to call the police, and that is not true. So I would encourage everyone to reach out to your 988 providers, reach out to, anyone that would be familiar with it. If you're not familiar with 988, and because it's a huge service to advocate for our patients. I tell them all the time, like, next time, if you don't want 5 uniformed people standing in your living room, reach out to 988. Unless you can't be safe, So
right.
Yeah.
And the added layer of having law enforcement that's trained.
Yeah.
Right. For in this system here makes, I'm sure, at least in my experience with them, a world of difference.
Huge. Yeah.
I interacted with those guys quite a bit. The area that I worked in just had a lot of that stuff, but I always would call. Like, I'd get on the radio and I'd be like, is, this team available? Are the CPs available whenever possible? Because there's so many things out there, not just, what we've talked about here, but like other layers to healthcare that I can't even conceptualize on top of everything else I need to know. Yeah. So that division is so important.
And I think for anybody that's interested in, taking their EMS practice outside of just, the street medicine and the 911 calls, which are great. And it's a great thing to be passionate about and be good at. But I think being a good provider is being well-rounded in what you know about resources. So you don't have to be a community paramedic, but you should know some of the basic resources that are out there available for people that don't entail calling 911 and going to the ER all the time, and presenting them in a non-punitive way. The degrading and patronizing of, you need to stop calling us, we have better things to do, you need to call this instead. is
so
not
dicey.
great. Don't do that, please, ever. But discussing with them, other resources that are available. So
Being a patient advocate,
Yeah.
just however that looks.
Yeah.
Do you feel like there's a certain type of EMS provider that you think would thrive as a community paramedic? Because I feel like a 22-year-old brand new paramedic, they want to go see car wrecks and all the crazy stuff and shock people and do all that, right?
Yeah.
Do you feel like there's like an experience level or anything specifically that you've seen that like, oh, this person would do really well in my job?
I think, a few years of experience. Part of that is getting your yah-yahs out on the big calls.
Yeah.
And I think a lot of it is so one of the things that was most difficult, I think, for a lot of us was people are sick and they're at home, and that's okay. We're so used to seeing someone sick, be like, you need to go to the ER. It's like, nope, they're sick. And this is what we're expecting. We're trying to keep you from getting worse, and we're trying to, relay these issues to your physician. Same with people that are having a mental health crisis. It was
So you're saying the maturity of it.
Being like, we're going to make the best decision we can in collaboration with all of our other partners, and do the best thing we can for this person. And that takes a little bit of maturity in your practice.
And personal.
Yeah.
I was a caregiver for a few years, and while I think that played a huge role, it's still like when I was thinking about the community paramedic role, I was like, those are some big shoes to fill. I feel like is in like the responsibility that you guys have, for like there's a lot that you have to be aware of.
Yeah. And
you either have to have seen it through experience on calls, personally gone through some of that stuff, or like known someone who did. And that takes time.
Yeah. When we first started doing the mental health responses and working side by side with the, master's level clinicians of the mobile crisis unit, I learned so much about mental health, so much about de-escalation, so much about assessing people in mental health crisis that I always tell people, like, I'm not a social worker, but I play one on TV.
That's super fun.
Or I could do it for like 15 minutes. And that's what the law enforcement officers and I always joke about. We're like, we're social workers for like a good solid 15 minutes. And then I need to pass it out to someone else. A lot of things can get resolved in 15, 20 minutes, right? People have issues and are in crisis in things that are not life-threatening. I needed a kind ear, and I needed somebody to give me some follow-up resources, so.
Yeah, and I think I just want to go back to kind of what you said of like letting people be sick is so, it sounds silly, but I don't want to say empowering, but it's like I teach my students that of like the confidence boosters of like, hey, you have someone who's here telling you like it's okay to be at home and feel like crap and have a high fever, like that kind of stuff. So if that makes any sense of like, you're also giving people kind of the permission to be like, hey, it's okay to feel like this. You have the resources, like you're saying.
Yeah.
Then they can make the informed decision as to what's appropriate. And most of the time, it's not informed because resources, like you were talking about, knowledge of them and access to them is the action part of it, I can see where that would be super difficult.
With you having worked with these, master level clinicians, as you call them, are there any resources that you've gained from them that you could share with people of like, this is a book that goes into de-escalation techniques that I know is really good, or a different podcast, or whatever it is? Is there anything that you've learned that you could kind of share with the next generation?
So I think if you can tie in with your local law enforcement agency and see if or when they do CIT classes. So law enforcement has called crisis intervention training. It's a 40-hour class that law enforcement will put their officers through. And within those 40 hours, there are they go through role playing and de-escalation. They have local experts come in and talk about resources. They talk about the different presentations of mental illness that go even further in depth than what a lot of us got in medic school.
I did mental health first aid when I was in paramedic school. Is that one that you would recommend?
Yeah, there are a few of those. There's mental health first aid. There are assist. There's it's called assist training. It's like applied suicide intervention skills. I don't remember exactly what it stands for now. There are a few of those, and anything that expands your knowledge of of how to talk to somebody and not being afraid to talk to somebody about their mental health, because I think that's where a lot of us stumble is, people, like to be, were you trying to hurt yourself? I'm like,
it requires you to be secure in yourself and in your own mental health, I feel like.
So, anything like that. One of the better trainings that I ever did was a motivational interviewing training, which is not something that ever gets done in EMS.
Motivational training?
Motivational interviewing.
Oh, so motivational interviewing.
It is basically, it was the first couple of hours, and I looked at my coworker, another medic that was sitting next to me. I'm like, this goes against everything we've ever learned as medics, because it's asking open-ended questions, and it's allowing somebody to kind of work through their own reasoning of how they can make behavior changes, or about, what caused these things to happen. And it was really, really interesting and very insightful, because I'm so used to asking closed-ended questions. I don't want to hear your whole life story. Just tell me about what's going on right now. But that doesn't, if you're looking to, de-escalate a situation or look into what is causing somebody's, readmissions to the ER, asking them yes or no questions is not going to get you the answers. So it was, it was a really interesting mind shift for sure.
The open-ended questions is such an art form.
Oh, yeah.
I think food service helped me with that. That sounds ridiculous,
No,
but that type of like shutting it on and then off at the times when it's appropriate, especially with mental health, where like you get people, and we all have that idea of like, if I say the wrong thing, or like I'm not the person who should be doing this. We've all done this exact thing. I'm not the person who needs to be helping this person, but then who is? And I think one of the things probably more first responders need to do is take accountability for not paying attention to some of those things when we're clearly getting calls for that. We're like not acknowledging that clearly this is a chronic schizophrenia problem that has something else going on. So.
And I think, like you said earlier, I'm talking about the elderly folks calling a lot, like loneliness, social disconnection, huge, especially in elderly populations. Like if you're going on someone a lot for low acuity kind of complaints, it's probably not the complaints. It's they get scared, they get lonely, they feel disconnected from any sort of social encounters or the ability to even just talk about how they're feeling to somebody is a huge driver of I think of repeat, like some low acuity ER visits. So.
Do you, having worked for a long time, especially post-COVID, do you feel like there's been a shift in that it's gotten worse in the post-COVID world?
I think so. I think it's post-COVID and honestly in social media.
Yeah, in social media, for sure.
Yeah.
I think that honestly drives a lot of the mental health calls that we get. There's a lot of
isolation and like separation from just communication.
And social media stuff.
Oh, yeah. Oh, you mean like just the whole existence of social media?
Well, I mean, I don't mean I'm vilifying the whole thing, but it is.
Well, I mean, like the negative, like there's so many of the negative aspects of it.
Yeah, the bullying and the blackmailing. Is very real. And truly, we can call it attention seeking, which every once in a while I get flashes of where I'm like, I step back and I'm like, wow, that was really smart. You know what I mean? I didn't know I had that in me, but I was on a call once with a teenager, super upset, a lot of, family issues, school issues, teenager issues, and then an underlying mental health issue as well. One of the responding officers
diagnosed.
Yes. Yeah. One of the responding officers had said to her, it feels like you're just looking for some attention, which obviously upset her. And he said that to me. And I said, okay, well, what if you are? Then let's figure out what that attention is. And how do we make it to where you ask for that in a much healthier way than what you're doing right now? And like I said, that was one of those where I was like, man, I can't believe I said that.
That's good. That's good.
But she felt so much better about that, right? I was like, asking for attention and needing something from people is not wrong.
Right. It's a basic life function.
It's human nature.
Yeah.
But the
we
way
want
that
attention.
you're doing it is pretty crappy.
Yeah.
Like, so
you can't be doing stuff like this.
Yeah, maybe stop acting like a little butthead. And, it is, like in my career early, you'd hear people like with that cut, that did self-harm, and people, they're like, oh, they're just, looking for attention, or and I'm like, well, okay, then let's figure out what attention they need.
I mean, we've all said this on calls. That's like to parents or, family members or whoever, where you're like, that's a pretty severe cry for help.
Yeah.
If that is the case, that defies the human brain. We don't do that, So even if it is,
self-harm is interesting, and that's it's another rabbit hole we could get down. But it is truly a stress relief for a lot of people, and it is not suicidal. And so that's another thing that one of the clinicians taught me and how to approach it, and saying like, this is a coping mechanism and it's not a healthy one. And so let's what other coping mechanisms can you work with your counselor on finding, and not shaming them for it, and not saying, I've heard people say, calling, attention seeking. I'm like, have you ever seen somebody with a lot of self-harm scars that wears short sleeve shirts? Like, nope. This is not.
They're not broadcasting it.
No, it's upper thighs or something like that, where it's easy to hide. Yeah.
So it is. The questions that I learned to ask those folks are, when do you know? When do you feel like it's gone too far? And what other ways can you work on managing this? Because it's a stress relief for a lot of people. So.
Did you, and I mean this completely sincerely, but did you go through a lot of your own kind of stuff while you were learning all of these mental health things and all of these things that you're seeing in your community? The hard parts of what you see in your community and all that. Did that affect you? Yeah,
it is a different level of stress to do this kind of work than it is to run 911 calls. I mean,
and it's in your home, where you live here.
Yeah, it's. Running 911 calls, it feels like there's a resolution to it, right? You do the thing, you get the meds, you make the pain go away, you manage the airway, and these are so much more longer term, where you're making referrals to resources and hoping, that people follow up and calling them later and saying, did you get the help that you needed? And then the level of frustration that comes from recognizing that there just isn't any help available for a lot of people. And they're basically you're going to have to get really, really sick before anybody's going to help you.
Yeah.
And that is really, really frustrating.
Yeah. Yeah. And I mean, the job itself is already, just having the paramedic title behind your name is stressful enough, that having the people's mental health carried into that as well.
Yeah.
It's a lot of pressure.
Funny side story. Last night I was on a call, and law enforcement who I work with and that requested me to come to the scene for the mental health call, at one point was like, oh, we need to get a bus so they can come check this person out. I'm like, I am a paramedic.
Well,
you guys know that, right? And they're like, oh yeah. I'm like, that's still my job.
Yeah. That's what I was going to ask you as one of the last kind of, I don't want it to be funny, but we all have that we make fun of each other, right? We make fun of flight medics because are you really that cool? And stuff. So do you get any flack? I know you said people are okay, Dawn, your calls last longer or whatever, but is there any of that rivalry?
I mean, not that I have heard from people. I think there's a lot, especially newer folks are like, man, I can do your job, which, it's standard. We get that all the time for all of our jobs. But it is, I think there's people that recognize their strengths in doing certain things. And I mean, when we very first started and the whole concept came out, we did get some flack for some people are you guys going to just show up and cut old people's toenails?
Yeah. Give them stickers and make them happy kind of thing. That's what I figured people would probably do.
I think a lot of folks wondered if our roles were going to end up as, pre-hospital CNAs or something, where we were going to go and help people manage catheters or something. No.
We're trying to help them not call you guys. Yeah. We're trying to let you sleep at night.
Yeah.
Don't get on us.
Paramedic out there, catheter maintenance is a part of your scope of practice. I had a nurse tell me that when I was in my clinicals. She's like, yeah, there's a cath patient in there. Go work on him. And I was like, I don't think that's in my scope. And she's like, you bet it is. And she pulled out my internship skills packet. She kept it. And that was unhinged. That was crazy. But then she pushed it back to me and was like, you're managing this toots. And I was like, what the heck?
Yeah.
So
Yeah, paramedic internships are rife with, you're like, oh, you're going to do this, aren't you? Yeah. When I was in school, there were a bunch of younger guys that I was in school with that would always complain that they had to be part of enemas being done. And I'm like, well, that's because you guys are dumb. Because if an old man comes in with belly pain, that's when you make yourself scarce.
Yeah. That's when you go get the warm blankets.
Yep. Like, I need to go start an IV somewhere.
So kind of same vein, are there any like real misconceptions you've seen currently about what community paramedics do? Or, because having been a street medic, like I have a very limited knowledge of what you do. And I think I had more knowledge than a lot of my coworkers, and I still don't feel like I know what you did. So do you feel like there's any consistent things that that you've noticed?
Well, I think part of it is like the general not understanding the way the healthcare system goes, right? Is, the number of calls we get, we're like, this person needs to be in assisted living. Well, first of all, I can't do that. Mm-hmm. Second of all, that's very expensive and no one pays for it. Same with the home health, right? So it's not so much directed at what we do. It's at that like we do a lot of education with all of our providers on when they make referrals, being like, thank you for your concern about this person. However, these are the things we're going to run into with some issues with it. And so, but not so much what we do. I don't know that there's, and again, it's just specific to what we do in our program.
For each system. Yeah. So each system's going to have their.
Yeah, and it's going to be very different for most places. But I don't want to speak to anybody else's program. But
yeah, that's fair. Well, is there anything else that you want to say? Any points you want to make, or have special things in your heart about this field? Well, honestly though, because like I said at the beginning, you're one of the. Most people are never going to get to talk to someone with your type of experience.
You're an OG.
Yeah, you're like a legend in this world as far as I'm concerned. So that's kind of why.
No, it has been so rewarding, and has been one of I love being a medic. I love being a street medic. I love running 911 calls, but doing this has been a different kind of rewarding and a different level of, like I said, understanding of humans, and has made me such a better, more empathetic person. Where, let's be honest, there's still some people out there that are just not great humans, but most people, it's that line, I can't remember where it came from, but most people are fighting a battle you know nothing about. Be kind, and that's where I think our jobs come from at the base, right? We don't know what caused this to happen. We don't know the 15 years of struggle somebody's had leading up to this one time that you're going to talk to them for 20 minutes. Be kind. Giving them a lecture on their life choices is probably not helpful. What you can do is make a connection and make them feel seen and make them feel understood and make them feel listened to. And that makes more of a difference, I think, than anything else.
And you don't need any certain certification for that. That's not a medic level thing. That's a whoever.
Yeah. That's a human, and it's intentional behavior too. You have to make the decision to want to be like that. You might be most people, I believe most people are pretty darn good by and large, but you have to push, you got to encourage. And
I got a letter a couple years ago that still will be one of the highlights of my career, from a guy that I'd responded to that had overdosed. And he wrote me this letter after he'd been sober for 2 years and told me that I had played a huge part in his recovery.
Wow.
And it was because I sat in the back of the ambulance with him and told him that he didn't screw everything up, and that he could move forward, and that and in it he wrote, "You sat with me human to human, and gave me love in a time that I didn't feel like I deserved it." And it still kind of chokes me up, because it was such a I didn't do anything cool. I just sat there with him and made him feel like he was a human being, and it for him to write a letter to me 2 years later was pretty rad.
Yeah.
So.
I think the really good, one of the lessons kind of on that line that someone gave me, one of my old FTOs, was because I was grumpy going on a site call at 4 a.m. because I'd gotten 30 minutes of sleep, and he was like, whatever you feel negative, you need to swing the pendulum and not overdo it. But he's like, you have to manufacture that or something. Like you have to do something to swing that pendulum, because that 20 minutes, they're seeing you at who you are as a person, as a provider.
Yeah.
If you're pissed off that you're there at 4 a.m. when they're wanting to kill themselves, you have to swing that pendulum. It might be super negative. You have to make something become super positive, because people just need you to be there.
Yeah.
And you can't be a turd while you're doing it. And that kind of stuck with me when I'm like pissed and I'm like, I don't want to be here. I don't want to be doing this. Someone's calling for help.
Yeah. And, we could tell people we get one chance to give people the trust in the crisis system and in an emergency response. And if we screw that up, that they're with the lifeline for somebody that might really need it someday. So
100%. Well, thank you so much, Dawn. That was super cool. And if anybody has any questions in the comments, definitely let us know. That there's so many other questions as far as like money and funding, Justin came up with a whole plethora of questions that we can always revisit or whatever. So thank you again, Dawn. Very much appreciated. So thanks for watching, guys. We'll see you next time.